So what do we do with a burn patient? So we finish the pre-hospital or the first aid at the scene. Once they reach the hospital, or if the patient is lucky enough to still have arms, wherein the EMTs or the paramedics can insert an IV access, then they'll start it at the ambulance. However, if the burn injuries are so severe, there may be no peripheral lines available to start. So once the patient gets to the hospital, doctor may have to insert a central line. So once the patient's airway has been stabilized, meaning we have an airway, we intubated the patient, they're on a mechanical ventilator, or if not yet, they're at least getting oxygen via cannula, mask, or however that will meet their oxygenation needs. First priority is fluids. The formula used is called the Parkland formula. This will use either LR or NS. Between LR or NS though, which one is preferred? LR would be better because it has some electrolytes in it. The formula is 4. We'll skip the first one. We will not use 2. We will use 4 ml. Okay, because this is an adult med surg, so we'll use 4 mLs per kilogram per TBSA. So we need the patient's weight. The problem here is when the patient gets to the hospital, was it right after the burn injury or several minutes later? Several minutes later, because again, the burn injury took a moment, right? So let's say the patient was on fire or got electrocuted. So things had to go through their process, right? So people helped them, somebody called 911. The ambulance has to get there, and then once there, the ambulance have to examine the patient, put them on the stretcher, back onto the ambulance, and then travel back to the hospital. So we lose time, correct? Okay. Timing is the most important consideration in calculating the fluid needs of the patient. This formula is the calculation for the first 24-hour fluid needs of the patient. So let's review back to what happened when the patient got burned. Did the patient now start having SIRS and fluid leaking and then edema? Yes. So remember we said the patient loses water absolutely as well as relatively, correct? So is there already water in the third space when the patient gets to the hospital? So is the patient's weight accurate? No. So we don't know what the patient's actual weight is. So therefore, is this formula going to be calculated in accurate fluid volume? So this will therefore be just an estimate. Okay, so keep in mind, this is an estimate. Okay, but it's better than nothing. So this is as close to an estimate as we can get. So what is it again? 4 ml times kilogram times TBSA. So let's go back to May Jean, who has left us already. May Jean had a TBSA of 50.5, correct? Percent. Do not convert that percentage to a decimal. Keep it 50.5. So how much will she get? Let's say she weighs 70 kilograms. No, I said she weighed 60, right? Oh, she was 60 kilograms. So 4 times 60 times 50.5. So she will get 12,120 ml in the first 24 hours. Imagine a 60 kilogram patient. Can a 60 kilogram patient get 12 liters of IV fluids in 24 hours? Oh, that's too much. Okay, that's what would we think, right? It's way too much. But yet, that's what the formula says we should give. So that means What can you imagine about the amount of fluid loss a burn patient suffers or sustains? So therefore, does the fluid loss stop after the patient got burned?
No.
They continue to lose fluid. So therefore, when do we start counting the 24 hours? From the burned injury. Because when did they start losing fluid? From the time they got burned. So again, Ms. Peters, this is the formula. 4 ml per kilogram per TBSA. So that's how we got 12,120. Get it? 4 times 60 kilograms times 50.5 TBSA. All right. So let's put that in the back burner for a while. So how do we give the 12,120? It says here, we give half of that during the first 8 hours after the burn injury. Therefore, when did we start counting the 8 hours? Okay, take note, it's not from the time of arrival.
Oh, from they got burned.
Okay, let's say she got burned at 8 p.m.
After you start.
Okay, so the scenario again. So imagine Mei Jean. So she was in the bathtub, correct? So when Adler realized his mistake, did he immediately call 911?
No.
Probably not, right? So he would be shocked. Well done. Call the RN. Hey, help! And then the RN comes in, does the same. What have you done? And then they call, right? They call, hey, come quick, come quick. And then when the EMTs came, so they had to figure out how to, because she was how old? 120. And then you burn 120-year-old skin with chemicals. So what will that skin look like when they pick her up? Like she would be like, ugh, right? So they had to somehow pick her up with all that pain, put her on the stretcher. And before that, the ambulance had to travel, right? And then when they came to the facility, they had to go into the elevator and then roll to the hallway, find Mei Jean. So a lot of time will be used up, correct? So will she get there in an hour maybe? Okay, optimistically, let's say she reached the facility, the hospital, the nearest hospital at 9 o'clock. Okay? So therefore, when we calculate, we weighed her, we did the calculation of her burn injury, and then we used 4 ml. So we got 12,120. So how will we divide it now? Because now, do we have 8 hours? We have 7. So therefore, half of 12,120 is what? Divided by 2, 6,060. So do we divide this by 8 or 7?
7.
We divide this by 7 now. So our infusion rate, so when we hang the LR, plus what will take up more time is the central line. Patient has to have a central line because with all that, again, 120 years old, you think she has good veins? No, so let's say we get a jugular. Okay, we get a right jugular and then we start giving, because will a peripheral line even take 865 ml? Not in a 120-year-old patient, right? So we need a central line to give this much fluid. What happens to the other half, to the other 6,060? We give it over 16 hours. Please be careful on the exam question, what the question is asking, okay? Because I could ask, how much will you give during the first 8 hours? Or how fast will you, how many mLs per hour will you give it? Okay, please take note of the question. Okay? Again, I repeat, these formulas are only guidelines. Why is it only an estimate or a guideline?
You don't know that's like something else.
Well, not only that, the weight, right? The weight is really not accurate. So that patient who got burned an hour ago does not have a baseline weight, okay? Because this is the weight of a burn patient 1 hour ago. You understand? Okay, so therefore, there's already edema forming. So the weight is no longer accurate.
What period is that again?
right here. 1874. However, because it's only a guideline, how do we know whether or not we're giving Meijin enough fluids? Is the weight accurate here? But remember, in kidney failure, in heart failure, what did we rely on? The weight, correct? Yeah. So we said we were very confident then that 1 pound loss or gain was 500 ml, 1 kilogram loss or gain was 1 liter. Is it true here? It will not apply here because again, is this weight accurate? No. This is a third spacing patient, so it's not accurate. So therefore, what do we base the accuracy or the effectiveness of our IV fluid replacement? Urine output. The urine output. So we need to have 0.5 to 1 ml per kilogram per hour of urine output. Or what's the minimum mean arterial pressure again? 65. So urine or the MAP, that will be our basis for evaluating. Let's say at, what was the answer? 865 ml per hour. The patient was only making 0.3 mLs per kilogram per hour. What do? You can do that automatically? Okay, so you notify the physician, tell them the scenario. Okay, here's Meijin. This is what we weighed. This is what we're currently giving. And she's only making this much for the last 2 hours. What do you want me to do? Then they'll tell you to titrate it. Okay, increase it by so much and then call me back in, let's say, 2 hours. Okay, so that's what we do. We keep adjusting because what will be our basis now for evaluating the effectiveness of IV therapy? The urine first, okay, the urine output of 0.5 to 1 ml per kilogram per hour, or a mean arterial pressure of 65 or better. Yes. Say that word first. Urine output first. So how do we know they're making 0.5 ml per kilogram per hour? What do we need? Insert a Foley catheter. Of course, you will get an order for that. Okay. Okay, I know it says here other indicators are blood pressure and heart rate are not useful, but what did we learn in shock? Was it useful? Yes, that's what we based shock on, right? Okay. But what's the priority? Urine output. Okay. And then, of course, watch for the development of ARDS. We'll get to ARDS again, module 6. And here's the thermoregulation. Keep the patient warm. Here's the urinary catheter to adequately measure hourly urine output. Clean sheets, we place it lightly on the patient because remember, there are burn wounds here. Although we take care of the wounds during the first 24 hours, which is the emergent phase, but that is not really the priority. The priority is airway and then circulation. But we begin wound care during the first 24 hours. This is just not the priority. We want to make sure the patient's stable hemodynamically first. Of course, will the patient likely have sustained other injuries besides the burn? Yes, because except Meijin was a frail old lady, but everybody else, every other adult, what will they do when they were burned? They will just, right, so they could potentially sustain other injuries, right? Like a neck injury, a fracture here and there because of the in the panic. These wounds are also deep, so we administer tetanus injection. Okay, good question, but we'll get to that under the acute phase. Okay. All right. Okay, we did that. So we're finished with the resuscitative phase. Let's go now to the acute phase. So this is from 48 to 72 hours now. So patient here would already be in the diuretic phase of AKI. So they're now recovering because they reached this phase. I mean, they stayed alive long enough to reach this phase. So therefore, did you do a good job with the IV replacement? Yes, because otherwise they would have still been in the resuscitative phase. So we reached the acute phase, they survived. Now your focus turns to the wound care and infection prevention and pain management. So these are now the focus of your interventions here. So the fluids, yes, they may still be on fluids, but not as much as we gave during the emergent. Okay, no more hundreds of mLs per hour. This is probably maintenance, let's say 84 or maybe 100 ml per hour just for maintenance. No more replacement. Okay. So John asked about antibiotics. Okay. Are these dirty wounds? Okay, so do we expect an infection?
Yeah.
When we treat it now, is it likely that it'll get reinfected?
Yes.
Okay, so therefore, what would be a better approach with antibiotic therapy? Local or systemic?
Systemic.
Knowing that there is no protection, correct? Absolutely no protection. So is this patient likely to be reinfected?
Yes.
And will they require changes in several antibiotics? So what's the consequence of doing that? We're creating multi-drug resistant organisms. So therefore, unless the patient has evidence of infection, meaning we see sepsis evidence, we do not give systemic antibiotics. What we'll do is topical. Okay, we'll do local antibiotics. We'll talk about the other complications here like pneumonia and ventilator-associated pneumonia later. This is module 6 again. So let's go to the infection control. Okay, so our best approach here, because again, there's no skin, so they're exposed to, plus this is a hospital, correct? So likely, no, hospitals have bacteria, organisms everywhere. So we try to do prophylactic by topical. So the dressings we'll use here, here's the rationale again, because of the loss of the epidermal barrier. So we have a very big portal of entry. We do not want to create multi-drug resistant organisms either. So therefore, we will have to do prophylactic. Go to the table. Okay, so here's the wound care now. So causative organisms could be their own normal flora because now the skin is broken, or it could be bacterial, fungal, or viral. One of the methods of wound care would be hydrotherapy. What is hydrotherapy? Like a whirlpool. Okay, so we use a whirlpool bath. However, we no longer immerse the entire body because during my time, we did that. We immersed the entire burn patient in a big bathtub, a stainless bathtub, but now we only use small buckets, okay, small basins for hydrotherapy. So we dip in each wound one at a time, meaning one arm at a time, another arm, another leg, or a part of the torso. Because what will happen if this arm grows one organism, this one grew a totally separate one. So we are doing cross-contamination. So therefore, when we learned that we were actually cross-contaminating and therefore making infections worse, so we stopped the whole body immersion. Okay, so we just dealt with one wound at a time. So we did separate PPE, separate wound care dressings for each wound. Okay, we didn't do them, let's say we had one tray and then use the entire tray for that patient for all body parts. No, we change gloves in between burn wounds. All right, so that's what we do. So PPE, we clean the environment. With that, we also clean the hydrotherapy equipment properly, because remember, other patients, other burn patients will use that. And the systemic antibiotic, again, says here appropriate use. When do we use systemic antibiotics again? Okay, only if there is evidence of sepsis, of a systemic infection. Otherwise, no. So again, here's the concern. We don't want to create antibiotic resistance between or among organisms. This is a massive injury, correct? Will it promote cortisol release? Okay, so the patient, even without diabetes, will have hyperglycemia. So manage that, treat that with insulin. Here is the, yes. I know this is sub-Q, this subcutaneous insulin. So it won't like, no, this is already after this is acute phase now. So all of those problems we had in the emergent, the hypokalemia, that's already resolved. So we use topical antibacterial therapy. The most commonly used burn ointment is what? What do you guys use? One over the counter. What do you put? What's that called? Silvadene. So Silvadene contains what two drugs? So what are the two drugs in Silvadene? Silver and sulfa. So there's sulfa there, there's a sulfa antibiotic, and then there's silver in it. So good combination, because silver has no, not antibacterial. Sulfa is an antibiotic. Silver is a bacteriostatic, has a bacteriostatic property. What do you say bacteriostatic? Prevents bacterial growth. It doesn't kill them, but prevents them from growing. You've heard of silver tip catheters, right? Yes or no? No, Foley catheters that have silver in the tip. The tip of the catheter has silver. Okay, we use that for long-term. It will cut down on CAUTI, C-A-U-T-I, okay? Because silver will prevent bacterial growth. Again, it does not kill bacteria. Okay, it can't kill bacteria. It can prevent them from growing. So here are the goals of your topical antibiotic therapy. So prevents these organisms, penetrates the eschar, but does not get systemically absorbed. So therefore, not systemically toxic. So we put this, all our dressings, therefore, will be cold and moist because of the Silvadene, meaning the dressings we have, the rolls of gauze, already have Silvadene on them. So we just wrap them on the wounds, and there's your topical antibiotic. So when applying your dressings, especially if it's circumferential, so how do we apply circumferential dressings? From proximal to distal or distal to proximal? Why distal to proximal? Textbook says distal to proximal. Why? Very good. So that's the rule. And what position do you put the limb in? Down or up? You elevate the limb. Because otherwise, how will it work if it's If it's down and then you do distal to proximal, you're still causing venous pooling, right? So you wanna, the objective again is to promote venous return, to promote circulation back to the heart. So you elevate the extremity and then apply it distal to proximal. This doesn't apply for burns only, okay? It's anything, any dressing, stockings, bandages, you always go distal to proximal. And this is, of course, common sense. Don't wrap it too tightly. All right, so the only one I'm testing here are two. We've got silver and there's only one. Only silvadine. So only silver sulfadiazine. Later, let's see. Okay. For debridement, once there's already eschar on the wound, we use a ointment called collagenase. This is what we call part of debridement. What is debridement? The removal of dead tissue. Okay. So when we do this, there's chemical, there's mechanical, and there's also surgical debridement. So for chemical debridement or natural debridement, we use collagenase. So using the ointment, you apply it on any eschar and it will literally eat collagen. It will break down the collagen in the eschar, dissolving the eschar and then exposing the granulation tissue. Because can granulation tissue grow if it's covered by eschar? No, it cannot get any oxygen, can't get any circulation. So you have to remove the eschar first by three ways, either chemical, mechanical, meaning with, let's say, hydrotherapy. Because hydrotherapy, the water pressure will loosen the eschar, or surgically. Here, surgical debridement. So mechanical, chemical, using collagenase, or surgical debridement. Surgical debridement can only be done by a provider or a surgeon. Now, don't take that literally because here, surgical debridement, they use a scalpel, right? To remove the dead tissue. When you're doing mechanical, so of course, if let's say they're doing hydrotherapy and then when you finish hydrotherapy, there were loose eschar hanging, do you really need a surgeon to cut that out? No, because technically, is it stuck to the wound? No, it's hanging, so you can snip that. Yeah, you can snip those, but they're not technically attached anymore. Okay, so they're attached on some other eschar, but since they're loose, you can cut those suckers out. Same thing for any other wound also. We won't do grafting. The only thing NCLEX will ask you about grafts is, how do you tell that the graft is infected? What are signs of an infection? Okay, the odor, the color, right? Yeah, the color, the warmth, the the discharge. So it's not any different whether it's a wound that's infected or a graft that's infected. Signs and symptoms remain the same. And you already know systemic signs of infection as well. So if this escapes local control, then you already know signs of sepsis. Let's talk about contractures, and that would be it. Contractures form on joints, correct? So it will cause joint contractures. You know what joint contractures are? Yeah, the elderly who are bedbound, don't move, and they're permanently in this position. Okay, like that. So what causes this? Yeah, this is not really arthritis. No, they're in this position like this. They're in a, they're in a permanent flex position. It's very difficult or impossible to extend the arm anymore. So what caused that? Okay, immobility, right? So they were just left in that position. So months, years passed. So the patient was seldom exercised. No, you use it or you lose it. So therefore, they didn't use the joints anymore. So they lost function of the joint. So they are now in a permanent contracture. So the joint has now fused. So we require surgery to restore range of motion. Now, if joints can contract, skin will also contract. You have scars, right?
Yeah.
Okay. Imagine if I don't have to see your scars, but if you have a scar, you notice that it's tight, right? Around, especially around the edges. Okay. So therefore, what did the skin do? It pulled, right? It pulled itself. So therefore, that's what a contracture is. So these are burn contractures, especially around joints. Nothing we can do with the skin, but contractures, just like joint contractures, occur over a joint. So therefore, if a burn involves two areas across a joint, it will contract. That's like here on the neck, for instance, or on the, let's say on the arm. We have several examples here of skin contractures. So this one here is another contracture, although this one was already repaired. So you can repair it, but will require a series of surgeries. So let's look at this example here. So this is now how it's restored. Okay, so they surgically repaired it, but until then, this was the... So look at the poor child's scar, right? So this is because the joint also was not properly positioned as the wound healed. So it created a contracture, limiting this patient's range of motion of the neck. So they surgically repaired it, and then they restored function. But this could have been prevented. Now, the general rule with contractures is you stretch the area because do you want it to flex or extend it? Extend. Okay, so if I ask you, and on the NCLEX, ask you, if the burn area is the neck, what position will you put the patient? Flex or extended? Extended. When I say extended, don't be a wise ass where you say, okay, the patient will have to be walking like this. No, when they sleep, you put them in a extended position. What if the area burned was the back of the neck? Will you do extension or flexion? Okay. What if it's in the antecubital space? What position will you put? Extension or flexion? Extension. What if it's my elbow that was burned? Extension or flexion? You get the idea?
Yeah.
Okay, so no matter where I put it, you can answer. Let's say the back of the knee. What position? Extend. The knee. The knee is flexion. Yeah, the back of the knee you extend, whether they're prone or supine, same thing. What if it's the circumferential burn? What if it's the entire arm? The whole arm was burned. What do I do? Do this? Well, in that particular, we will have to use garments now. So we have compression garments. So we have compression garments from, we can have head to toe. Okay. Specify burn. Like this. Okay. So if it's the entire face, we can't flex or extend the face, right? Or the head. So if it's that's the case, then we wrap it with compression garments. Hey, we have one for head to toe. Like you can wrap the entire body. Say the entire or almost the entire body that's burned. We have compression garments for that. Okay. So they just wear that so that they don't form ugly scars.
So that to help protect it.
Well, for the scar to form, uniformly, not forming a contracture. Because again, the objective is to stretch the skin. So you can stretch the skin by applying compression garments. Yeah.
Compression garment. Is it to prevent blisters?
No. This is now the acute phase all the way to the rehab phase of burns. Because blisters will form whether you like it or not, because that's caused by the separation of the skin layers, right? Because of the burn, they form blisters. Meaning as the capillaries leaked, it leaked out of the capillaries, but then the skin was intact. So that's why the blister forms. Let me check if we're finished. So I said we don't do graphs. These are all graphs now. Okay, pain management. And this should be it. For pain during the emergent phase, what would be the route for the pain management? Considering the GI tract has low motility, the kidneys, there's decreased urine output, the muscles are injured. So what would be IV? Okay, so IV, just watch the dosing though, because remember the patient's in AKI, but they need opioids, okay? Of course, just have the antidote on the naloxone on standby. Benzodiazepines may also be beneficial because these patients, they're scared, right? They're in panic, worried about now what will I look like? How am I gonna take care of my family? Will my spouse still love me? Okay. So scary period. One of the let's go back to the signs and symptoms. Are fourth degree burns painful? Okay, good thing you mentioned that because let's examine that. Okay. Theoretically, let's look at the table. Okay, so here this is table 57-1. So superficial, yeah, there's pain. Partial thickness, pain. Full thickness, as it mentioned. And then full thickness. Okay, let's go to the paragraph. There is pain mentioned. Okay, burn depth. First degree painful. Second degree painful. Okay, first. This is again superficial. Okay, pain. Okay, pain. Second degree, right? Okay. And then here it says full thickness, no pain. And that's lightning. And okay, abdominal pain. All right. Is there such a thing as a uniform burn? Like it's only one depth all throughout. Is there a uniform burn that all will be? No, with major burns, of course. With let's say you touched a hot pot, yeah, of course that's minor. But we're talking about major burns here. Is it really? So let's take a full thickness burn, okay? Deep full thickness all the way to the muscle and bone. Is it gonna be uniform? Because as you go along the edges, there will be second degree and first, right? So there really is no such thing as a painless burn. There will always be pain, correct? And some people also report, because remember, there are nerve endings there too. So if there was pain in phantom limb, when there is no limb to speak of, will there be some pressure type pain here in these deep wounds? Yes, there will be. All right, that would be it.